In the following video, we will demonstrate several applications of confocal endomicroscopy for colorectal polyps. In the first video, we identified an area of very subtle abnormality, and it was unclear if this represented a true polyp or not. The lesion is now seen in the central part of the window. Notice we're using a cap to stabilize the image, and we're using both white light and narrowband imaging to further clarify if this abnormality is truly a polyp or just some overlying mucus, period. In the first image on white light, we see some slight thickening of the epithelium and slight loss of vascular pattern. On narrowband imaging, there's a slight reddish pattern to it. Also note that during the transition between white light and narrowband, there's a slight yellow-golden color suggestive of overlying mucus. We now apply confocal endomicroscopy to this lesion, utilizing the cap to stabilize the image. Again, notice the slight reddish or golden yellow pattern on the narrowband imaging suggesting overlying mucus. This raised suspicion for a serrated adenoma. On confocal endomicroscopy, the tissue is abnormal. There are villiform changes, as well as thickening and darkening of the epithelial border. These are features suggestive of adenomatous tissue. In addition, some of the crypt openings have a stellate pattern, which are features typically seen in hyperplastic or serrated polyps, period. In these findings, we concluded that the tissue is likely a sessile serrated adenoma, and thus proceeded with endoscopic removal of the polyp using standard polypectomy techniques, and final histology confirmed a sessile serrated adenoma. We now move on to the use of confocal to evaluate EMR sites. You can see here a scar from a previously resected large flat polyp. There's an adjacent tattoo mark to confirm the location. The scar itself appears bland and white, but just above the scar there's a slightly raised area concerning for some residual adenoma. On narrowband imaging, there's slight irregularity to the mucosal pattern and villus pattern. However, these were not definitive for residual adenoma. Using confocal endomicroscopy in this setting is very helpful to determine if further resection or ablation is needed. Applying the confocal probe-based endomicroscope, we can obtain good imaging of the tissue. Here you can again see the cap used to stabilize the image. Once in good position, we can visualize the endomicroscopy view. Again, we're looking for areas of darkened epithelium, which are clearly evident in this case. There's areas of very dark and thickened epithelium, which in this case were highly suspicious for residual adenoma. As part of an ongoing study, we confirmed these sites with biopsy and then performed ablation or resection. In this case, because of the adjacent scar tissue, further resection was not feasible, so we simply ablated the site using argon plasma coagulation. Without the use of confocal endomicroscopy, we would have to make a decision whether to empirically treat just based on the endoscopic view or to take a biopsy and bring the patient back for a later procedure. In this case, if we had only taken a biopsy, we would have had to perform a repeat procedure. Final histology confirmed a residual tubular